I have 35 to 50 children. And every year we send them to camp.
Yes.
Until last year, when most of the kids were on Hydroxyurea, I can attest to this, that almost every year we have 3 or 4 kids being admitted to the hospital. But last year, for the very first time, only one child was sick, wasn't even admitted. So I will say to you that we think it works and it works very well. But my question for you is this, Dr. Claudio. If I, as a parent, am concerned about putting my child on Hydroxyurea, what other choices do I have, and what compared it to?
So that's a good question to address. So currently, the one alternative up until now, the alternative if your child, before Hydroxyurea came along, if we had a child who was frequently in hospital, what we would do is put them on a chronic transfusion program. So transfuse them on a monthly basis. We used to do this for about 6 months, give them a rest, we call it give them a rest from coming into hospital, 6 months to a year, and then we would stop them at about a year because every time you transfuse, you give a load of iron. So then we don't want to have to put them on the medication at the time, I'm talking before Hydroxyurea, which was a needle every night, overnight, so to take the iron out. So we would give them a rest from the hospital for 6 months to a year, and that would keep them out of hospital. Once Hydroxyurea the studies came out, then we put them on Hydroxyurea, and those chronic transfusion program to prevent crisis have pretty much stopped. We do have 2 patients now who have been started, and we actually just wean them off and put them back on Hydroxyurea. There is one new drug that's coming. It's called Hemocrest, which will be trialed at SickKids. It's going through the research ethics process right now, and this scientific review board and all that. And it started already in the U.S. In trials, and we will be starting trials in Hemocrest. What I understand, I don't know a whole lot about the drug. What I understand, it's not from a similar class of drugs like Hydroxyurea. And I asked in preparation for coming here today, I said, what have people noticed as side effects in the States? And they said nausea and vomiting, GI upset, and nothing else. And that's the beauty of the drug. So it's not from this class of drugs. And so the trials are ongoing now in the US, and we'll be starting soon. We're always a little bit behind, but our Health Protection Canada is very stringent, and they hold up a lot of things from just in the interest of protecting patients. So those trials will be open. So if you come to clinic, you can ask about the Hemocrest study. Some of you on Hydroxyurea may want to, may be interested in switching to Hemocrest and study. Others, I see a head shaking, would say, let sleepy dogs lie, working well, just leave it alone. And then we would be approaching patients who we think should start Hydroxyurea. We'd be offering them Hemocrest on a research study basis. So that's coming.
My daughter, she's 6. We find out
Sorry,
that she's sickle cell disease when she was 4 years old, before the baby. And since then, she has been admitted to the hospital 2 times. And now
I'm sorry, can you stand up? We couldn't hear you in the back.
Sorry, she's on folic acid and penicillin. I would like to know what is the difference between those 2 drugs and hydroxyurea.
So penicillin is an antibiotic which we give to all children from birth, as soon as you find out, until age 5. And there are few, so by age 5 you can usually stop. There are few kids we continue for very specific reasons. We know that and this is historic, that one of the causes of death in children under the age of 5 is pneumococcal infection. Pneumococcus is a bacteria that has a surface capsule, and the spleens in children with sickle cell disease don't work well. And you need your spleen to get rid of that capsule and kill the bacteria. So kids with sickle cell disease are at risk for pneumococcal infection. Now we have good vaccination, better and better vaccination than we did before. So we know it's been shown in the US and Jamaica, pretty much everywhere. If you give penicillin up until the age of 5, you prevent death from infection. So the reason for penicillin is to prevent death from infection. The folic acid is in any rapidly turning over set of cells, like blood cells in sickle cell disease, you use up a lot of folic acid. And folic acid used to be given to everybody to prevent them getting deficient because your hemoglobin could drop over time. Nowadays, we have folic acid supplemented in flour products. So all the breads and pastas we eat, we have folic acid in there. You get folic acid from green vegetables, which a lot of little kids don't like to eat. So now we're actually not seeing folate deficient patients. We do measure it once a year when you come to clinic, but we haven't had any folate deficiency patients. So we're not as stringent about using folic acid. Some patients come to Canada already on folic acid from countries that are not supplemented, and they want to continue, and that's fine. It's not harmful, and if you want to continue, and some doctors still prescribe it routinely. I personally prescribe it in patients who on hydroxyurea for sure, because you want to drive those cells, but also in patients who have very low hemoglobins, I would take them. But the SC patients, I wouldn't give folic acid. SS patients, it's a very individual thing. And so they're different, completely different drugs for different reasons. Penicillin doesn't stop you from getting a crisis. It stops you from dying from pneumococcal infections. There's a lot of misconceptions outside, and people come into hospital and say they're on penicillin, they still get a crisis, so they don't want to go on penicillin. It's not that it doesn't impact crisis, but it's to prevent infections from these specific bacteria.
Speaking about alternative ways of dealing with sickle cell, I've come across a couple of articles talking about bone marrow transplant. And surprisingly enough, 2 of them were done with sets of twins, where one sibling was having a lot of difficulty, and they had this bone marrow transplant done, I guess, and then they've not been in hospital. It's been like several 9 years, no episodes, decrease of fatigue, and all that stuff, just all the things aside. Now, is that only SC patients, or is it SS patients, or what's your thought on that?
So everybody heard the questions about the role of bone marrow transplant in sickle cell disease?
No.
So we have had, at Sickles, we've done 1 sickle cell patient, somebody who, for very specific reasons, and because there's only 1 patient, I can't talk about the patient because people may know that individual patient. But sickle cell disease is one of the conditions that, so what a bone marrow transplant does is what you do is you give chemotherapy to the patient, and it wipes out their own bone marrow, and then you infuse fresh bone marrow in a patient who's a perfect match, usually from a brother or sister from the same parents, and you infuse the bone marrow, and it goes into the bloodstream, it goes to the bone marrow, and it starts populating the person's bone marrow. So your bone marrow in future is whatever reflects your donor. So if you have sickle cell disease, your donor can't have sickle cell disease because that would make sense. But if you had sickle trait, or you had not even sickle trait, then that's what you become. So it's actually a cure for sickle cell disease. Currently, we would only, other places are doing other things, but we would only do it in a patient who has a perfect match, an HLA match, and that's usually a brother or sister. It's a high-risk procedure. For the first 3-4 weeks after you've given chemotherapy and wipe out the marrow, when you wipe out the marrow, you wipe out all blood cells. So you have to support with red cells transfusions, platelet transfusions, and your white cells, you have to wait for them to come up on your own. If you get infections, you get antibiotics, and we can do a good job now, and fewer people that are dying as a result of the procedure, but it's still a high-risk procedure. When it works, you're cured of your sickle cell disease, SC, SS, whatever, thalassemia also, when it works. A few complications is that if there are a lot of things that make all of us different from each other. So even if we have a perfect match in terms of some specific typing from our brother or sister, they're not exactly identical in the genes. So when the donor marrow gets into your body, the cells recognize it's in the wrong person, and then they start to fight, and that gives something called graft versus host disease. So you could end up cured of your sickle cell, but you have a new disease, graft versus host disease, which can leave you with various degrees of skin rash to sloughing, liver disease, lung disease. So you might end up with in a worse scenario than you started. It's good when you have a good match and you have a good indication. So like anything else, if you have a patient who's had multiple strokes, is on a chronic transfusion program, and they're starting to develop antibodies, so it's becoming more and more difficult to transfuse them, and they have a sibling, a brother or sister who's a match, that's a good reason for doing it, for taking that big risk, because ultimately you won't be able to transfuse that person. So that's a good reason. So currently, there are individual patients who we're matching their brothers and sisters who are on a transfusion program because they've had strokes, and to try and find a cure for that patient on a chronic transfusion program. We're not in a position at this point taking patients who are otherwise well, and just because you have a sister or brother who's a match and transplanting you. Do you understand what I mean? You again, balancing risks and benefits. So that's not to say that in the US, I know that one of the basketball players in the US, his little boy got a transplant from a sibling just because he had sickle cell disease and he can cure it, and lovely, he's done well. And as time goes on, that will happen more and more. And it has happened transplants started in Brussels, where a number of African diplomats were going back to Africa with their children after their time has finished as diplomats, and they had their kids transplanted with sibling donors. And they've done well, most of them. The reports are always about the ones that do, reports are so wonderful, then I wonder about graft versus host and the ones that, not hearing, the complications you're not hearing about. But that's not to say that you couldn't bring it up and as a discussion when you come to clinic about your own child, and we can review your own child. There's some places that are considering unrelated donors. So you have the bone marrow registry, and you might be a match for your child who's not related to you, but a close match, and might do that. Again, that carries higher risk for graft versus host. Again, balance risks and benefits.
Would you giving your bone marrow to someone, would it affect you as an individual?
No.
Like short term?
So in the very short term, to get the bone marrow out, actually they're not even doing that now. So up until a few years ago, to get the bone marrow, you'd be put to sleep, you as a donor. You put a needle into your hip bone, and we sit there and pull syringe out a whole ton of bone marrow from you. So you might feel a little tired the next day, and you're sore as ever right here on the hip bone. Nowadays, they actually put an IV in and put you on a machine and take off the stem cells and then replace the other cells. So it's a lot easier.
But do they give you strength in terms of?
You could take iron tablets before and leading up to and afterwards to strengthen you. But your own bone marrow being healthy will recover quickly, and it shouldn't be a reason not to be a donor. And then on that note, if I could just talk about donations. Blood transfusions in sickle cell patients, most of our donor population is Caucasian population. So we have now about maybe 50 or 60 kids being regularly transfused every month. That's the kids, and then they're adults also. And some of these patients are developing antibodies because there's a lot, again, the genes are different between Caucasians, blacks, Italians, everybody else. So most of the donor population is Caucasian. We really need to get our population to become donors for our own kids, to help our kids, because our kids will develop antibodies because they're being exposed to proteins that are not similar. They develop antibodies, and there are times when our patients can't be transfused because they just can't get a good match. So this is a plea for going back to all your churches and communities and asking people to go in and donate blood and be going bone marrow registry.
So if you have the trait or you have sickle cell yourself, can you donate?
If you have the trait, you can donate.
Right.
You wouldn't be able to donate as a sickle cell person because you need to have a normal hemoglobin, and so you never really get up there.
But in trait you can donate.
Trait you can donate, yeah. And trait blood is healthy. It's just that when our patients are being chronically transfused, we're calculating how much sickle hemoglobin, we're trying to keep them under 30%. If you get a donation from a sickle trait, then it messes up your calculation. But in an emergency, we will transfuse a sickle cell SS patient with trade blood in an emergency.
So
But
they know that based on the card that you fill out, like that
It-
you're a trait?
they test it,
They
test
test
it,
it
yeah.
before, okay.
And you know, there's a lot of information, if you know, there must be a questionnaire that when you donate that you will ask if you're trained. But it's not a reason to not to donate. Do you want it? Do you think you can get it? Pardon?
Any more questions?
We,
Any more questions?